Good morning, good afternoon, and good evening, everyone. Welcome to today's webinar, Inside the World Health Organization's Meningitis Guideline, Diagnostic Recommendations, and Clinical Impact, hosted by Mario. My name is Kelsey Brown, and I'll be your moderator for today's session. So just before we begin, I'll just run through a few housekeeping tips for everybody. Today's event will run for approximately 60 minutes, so that doesn't include time towards the end for our Q&A with our speakers. So now it's my pleasure to introduce you to our speakers joining us today from the United States and Spain. We have Dr. Kiran Thankur, Herbert Irving Associate Professor of Neurology at Columbia University and Neuroinfectious Disease Fellowship Program Director at Columbia Irving Medical Center, New York Presbyterian Hospital. And then we also have Dr. Iolanda Jordan, Professor of Pediatrics at Barcelona University and Deputy Medical Director and Chief of the Critically Ill Patient Center at St. Joan de Dieu Children's Hospital as well. Our speakers are distinguished experts in neurology and infectious diseases and offer a comprehensive understanding of the World Health Organization's Meningitis Guideline. And we're really pleased to share their insights with you today. So with that, we're going to begin, and I'll pass this over to Professor Jordan.
Good afternoon and good morning, ladies and gentlemen. First of all, thank you to bioMérieux for inviting me to participate in this interesting webinar, all together with Dr. Thankur, and it will be my pleasure to share my presentation with all of you. These are our disclosure, and none of these relationships have any direct influence on the interpretation on content of this presentation. Next, please. Then in this session, we will examine the most relevant diagnostic recommendations from the WHO Meningitis Guidelines, focusing on how they apply to daily clinical practice. We will go beyond a basic summary and discuss how these guidelines influence real-world workflows, decision-making at the bedside, and management in complex populations, such as neonates and immunocompromised patients. The goal is to translate guideline statements into practical, actionable steps. Next, please. So, as you are aware, these guidelines were published as a global roadmap for defeating meningitis by 2030. The initiative is broad, and it includes improving prevention through vaccination, establishing rapid diagnosis capacity, enhancing clinical care pathways, and minimizing mortality and long-term sequelae. It is a reminder that meningitis is not only a clinical emergency, but also a public health priority requiring system-wide action, which includes mitigating the risk of antimicrobial resistance and, of course, improving the quality of life affected individuals, families, and communities. Next, please. Then let me move to the global burden of meningitis. It causes 5 million new cases globally and 300,000 deaths per year, and also carries a risk of epidemics. Then the burden is unevenly distributed, as you can see in this figure, with the highest incidence in the African meningitis belt, but cases occur everywhere. And as all you know, young children are the most at risk, with around half of cases and deaths occurring in children under 5 years of age. So what is important for clinicians is that despite vaccination, meningitis continue to cause significant morbidity. With respect to the etiology, there are some differences between high and low income countries. And as you can see, in high-income countries, the widespread implementation of vaccines has substantially changed the epidemiology. In neonates, vertically transmit pathogens such as Streptococcus, Agalactiae, E. coli, and Listeria still require special attention. Pneumococcus remains the dominant cause of severe bacterial meningitis, meningitis, altogether with Streptococcus pneumoniae and Haemophilus influenza in children and young adults. And these etiological patterns influence, of course, the empiric antibiotic choice, as we will see later. If we move to the low-income countries, the etiologies are quite similar, but with a higher incidence due to low vaccination coverage. Therefore, vaccine-preventable bacteria remain dominant, but in any case, one needs to think in other etiologies, as for example, Mycobacterium tuberculosis in certain regions, and remember the meningitis belt in Africa, from Senegal to Ethiopia, where Neisseria meningitidis remain a major cause with periodic epidemics. Next, please. With respect to the viral infections, all we know that symptoms tend to be milder, but clinicians must always distinguish viral from bacterial meningitis early. In high-income regions, viral meningitis is most commonly caused by enterovirus, as you can see, mainly by Coxsackie and Echovirus. And herpes simple and varicella zoster are less frequent, but highly relevant due to their severity and need for immediate acyclovir therapy. In low-income settings, enterovirus is also quite frequent, but underdiagnosed because they usually do less PCR panels. But what is relevant is that vector-borne viral pathogens are more prominent. And I would like to emphasize the need to consider geographical exposure and seasonality. And for example, one can suspect different arbovirus depending on the region. For example, in Africa, you will need to think in West Nile virus or chikungunya, or in Latin America, just about Zika virus. Anyway, this virus can present with meningoencephalitis and sometimes are quite indistinguishable from bacterial meningitis at onset. Next slide. Now I would like to draw your attention to the meningitis clinical presentation. Classic triad of meningitis consists of headache, neck stiffness, and altered consciousness, all together with other symptoms like here in the slide, such as fever and photophobia. But I would like to highlight that these symptoms are often absent, especially at early stage, and in fact, classic triad only occurs in 41% of cases of children with acute meningitis, being more common in patients older than 60 years. Babies and toddlers require special attention because rarely exhibit classic signs. Instead, irritability, lethargy, poor feeding, apnea, temperature instability, and bulging fontanelle are more typical, and sometimes the only sign is a persistent and inconsolable crying. Because these symptoms are non-specific, clinicians must maintain a high index of suspicions and act quickly in order to avoid delays in treatment. And just remember that altered mental status is one of the strongest predictors of bacterial meningitis severity, and seizures may be also an early sign of cortical irritation or intracranial hypertension. Next slide. Dr. Thakur will follow with the presentation.
Thank you so much, Professor Garcia. It's such an honor to be here to speak to you about the WHO guidelines for bacterial meningitis, which I was really honored to be a part of. Next slide. So as Professor Garcia mentioned, a major breakthrough really happened in 2020 and 2021 when the Defeating Meningitis by 2030, a global roadmap, was approved by the World Health Assembly. And this really has very strong recommendations globally for eliminating epidemics, reducing the morbidity and mortality associated with bacterial meningitis worldwide, and is a mandate for regions across the world to really establish vaccine preventable bacterial meningitis as a primary pillar in their public health systems. And this global roadmap really used the 5 pillars that is mentioned here, including prevention and epidemic control, emphasizing diagnosis and treatment, disease surveillance, advocacy and engagement, and then support and care for people that are affected by meningitis, including caretakers. Next slide. The overall framework for the global roadmap to defeat meningitis by 2030 really had some major cross-cutting inputs and outputs that would be measured by critical outcomes for their impact. And as I mentioned, really the impact would be to completely eliminate epidemics of bacterial meningitis, reduce cases and deaths of vaccine-preventable bacterial meningitis, and reduce the significant disability and quality of life that we know is so prevalent in bacterial meningitis across ages. Next slide. So these are the visionary goals of this document. And the guideline scope, although extensive, did exclude certain components that are established in other WHO and global guidelines. And that includes meningitis in newborns, which is a unique cohort that requires specialized expertise and has a specialized guideline that has been developed. It does not address hospital-acquired, nosocomial, and healthcare-associated meningitis, and then does not directly address subacute and chronic causes of meningitis, including tuberculosis, cryptococcal, and eosinophilic meningitis, and does not directly impact and address non-infectious meningitis, which are also important causes, including those that are developed by drugs, malignancy, and other autoimmune diseases. Next slide. As an output of this, incredible document on the global roadmap was the WHO guidelines on meningitis diagnosis, treatment, and care. And this was published recently in April of 2025 after at least a few years of work on this document, systematic reviews, and the Guideline Development Committee meeting. This really was the first such document globally to address bacterial meningitis diagnosis and care, which I think is, very much monumental. And this was evidence-based recommendations on the clinical management of children over 1 month of age, adolescents, and adults with acute community-acquired meningitis. Next slide. So the guideline scope focused on the following etiologies of bacterial meningitis, as is shown in this table, including the major causes of vaccine-preventable community-acquired meningitis, and excluded, as I mentioned, the categories that we were discussing earlier. Next slide. Early diagnostic recommendations really focus on the importance of early lumbar puncture for the diagnosis of bacterial meningitis, which is a fundamental procedure that we know really impacts our ability to diagnose the specific pathogen that is causing the meningitis. We know that diagnosis is really established through a combination of clinical features, as Professor Garcia was mentioning, CSF and blood test results, including blood cultures. And the lumbar puncture is really fundamental and a mainstay of meningitis diagnosis. Next slide. In the guidelines, there was an acknowledgement that there is really, I think, a broad representation of what is now being called as the TAP gap, and this is from a publication that emerged from colleagues in Zambia, and we've done some work on this, in which we know that in cases of presumed bacterial meningitis or other infectious causes of CNS infections, we know that LPs are not performed, and there's a variety of reasons why this occurs. One is, on the patient side and their hesitancy in terms of getting the procedure. It may be that oftentimes the materials are not available. There's a lack of laboratory infrastructure in terms of the ability to perform rapid microbiological testing. And then the interpretation kind of may be a challenge in terms of the CSF results. The presumed danger of the procedure, which we know in the vast majority of individuals is very, very safe, is also a major hesitation. And so in areas that we know have very high rates of bacterial meningitis, including those that are epidemics, we know that LPs are performed much less than they should be. And this is something that was addressed in the guidelines, and there are implementation strategies for us to really improve on the numbers of lumbar punctures that are done globally for presumed CNS infections, including bacterial meningitis. Next slide. In terms of the laboratory recommendations on the cerebrospinal fluid, one is that you want to measure the opening pressure, and then the basic CSF profile. So this is the CSF white cells and the differential count, the red blood cells, the CSF glucose and protein. And that pattern, which is typically with a community-acquired bacterial meningitis and an otherwise immunocompetent individual, is a high CSF white blood cell count that is predominantly neutrophils, oftentimes with a low glucose and elevated CSF protein, is often something that we're looking for when we have an initial suspicion of a community-acquired bacterial meningitis. There are other important tests, as I mentioned, blood cultures. We also can measure the lactates, which can help us to differentiate a viral versus a bacterial process. So the CSF can give us a lot of information, and then we send the CSF off for different diagnostic testing that will hopefully help us establish whether this is a bacterial pathogen, what that pathogen is, and whether it's susceptible to our antimicrobials that we have started. Next slide. So one important aspect of the guidelines that we really emphasized were the research gaps and the gaps in information that we have. So one of the kind of aspects of this guideline is really how to address these gaps and move the needle forward in the field. These were some in terms of the diagnostic gaps that were established. Given the increasing availability of point-of-care tests in resource-limited settings, there was really a lack of data that was emerging out of these settings that we really needed to have in order to develop robust guidelines in terms of their clinical applicability. Also, antigen detection tests, and I'll speak to some of the specific tests that were available, are not included as part of the recommendations, although further studies are really needed to evaluate their diagnostic performance, particularly in field conditions, and support their widespread use. And then novel diagnostics, including host biomarkers, metagenomic sequencing techniques, which is increasingly used in resource-rich settings, really was not identified to have much data, especially coming out of resource-limited settings, to address this in our current version of guidelines. Next slide. So the recommendations in terms of specific diagnostics really remained that the gold standard for bacterial pathogens is going to be the culture and gram stain, and then antimicrobial susceptibility testing. That should be tested on all patients with suspected bacterial meningitis. There's increased recognition, though, that PCR methods, so polymerase chain reaction methods, have emerged and are highly sensitive and specific tests that can be used to detect bacterial or viral DNA and identify a causative pathogen. This can be particularly relevant and useful in individuals who have been started on antibiotic therapy before the CSF has been sent for testing, and those that are maybe early on negative for culture results. The available PCR platforms include single target, or what we call singleplex, or multi-target or multiplex panels, which are increasingly used and can test for multiple pathogens in a very short period of time on a very low volume of fluid. And this can be very, very helpful for CSF studies, especially in our pediatric populations in which we can't really get a huge volume of CSF oftentimes. So this was a strong recommendation, which included that in individuals with suspected acute meningitis, PCR-based molecular tests for relevant pathogens should be performed on CSF fluid samples, again, in conjunction with gold standard testing, including bacterial cultures. Next slide. So this recommendation was justified because of, I think, the overwhelming evidence that individual PCR testing can be highly sensitive and specific for the most common bacterial pathogens. And as mentioned, multiplex PCR also demonstrates an overall high diagnostic yield. The sensitivity and specificity, though, may vary substantially based on causative pathogen and setting. So in particular, we need to utilize the clinical context in terms of the interpretation of our results, as always. Next slide. In terms of some of the research gaps that were identified specifically with regards to PCR testing and molecular assays, the group really felt that enhanced global efforts to develop quality assured molecular assays that could inform clinical decision making, especially in resource limited settings, was really necessary. Diagnostic performance of CSF PCR for multiple pathogens, using a combination of clinical judgment, CSF characteristics, and CSF cultures as a reference standard needs to be further evaluated as well. And then the clinical applications and diagnostic performance across multiple settings, including epidemics, was felt to be limited in terms of the data that was available. Next slide. In terms of management recommendations, I think the overall recommendation is that we should start antimicrobial treatment broadly and as early as possible when we're suspecting bacterial meningitis. Really, the forefront of our goals are to treat the disease and to treat it effectively and rapidly to reduce the overall morbidity and mortality. The recommendations are included here in terms of specific treatment for the pathogens. Before pathogens are identified, it's recommended that there be broad antimicrobial treatment with a third-generation cephalosporin, as well as vancomycin, and also consideration of ampicillin for listeria coverage in young children, as well as individuals who are immunocompromised and those that are over the age of 60. I can't emphasize enough the importance of what we established in the guidelines with respect to supportive treatment. So the most important aspects of what we do for meningitis is not just to identify the pathogen and to treat with antimicrobial therapy, but it is to reduce the complications of things like elevated intracranial pressure, to reduce the seizure burden that we have. Often these patients are in status epilepticus, to make sure their sodium levels are stable, and then to provide early and aggressive rehabilitation care. And we had done a number of evaluations in terms of the potential sequelae of bacterial meningitis, including hearing loss and other functional neurological deficits. And we know the burden is at least 20%, likely much more, especially in vulnerable populations. And it's very important that we study this more and we develop adequate outcome tools, which are now being evaluated by the WHO teams, that are applicable to populations worldwide in varying settings. And that's one thing that has really been emphasized by these guidelines as well. Next slide. So I'll hand this over to our professor, who will speak to us on clinical practice and additional considerations.
Thank you, Dr. Thankur. Next slide, please. Then this slide explores how WHO recommendations shape practical workflows. And as Dr. Thankur said, they support a more structured triage system, encourage immediate empiric treatment when meningitis is suspect, and recommend early use of molecular diagnosis tests. So when you suspect meningitis, the first step is to evaluate the patient with a pediatric assessment triangle, and then to start the ABCD procedures, and just think if the lumbar puncture is contraindicated or not. If it's not contraindicated, then you will need to take the blood sample and the hemoculture, and of course the lumbar puncture, in order to determine the biochemistry, the gram culture, PCR or PCR panels, and also the lactate. In any cases, as for example in respiratory or hemodynamic failure, or in cases with coagulopathy, or if you suspect intracranial hypertension, then the lumbar puncture is contraindicated, so you will need to take the blood sample and the hemoculture, but immediately to start the corticoid treatment and of course the antibiotic treatment. In these cases, you will need to proceed with a CT, sometimes with contrast if possible, before the LP, and only when there is a correction of the contraindication, you will proceed with the lumbar puncture. Then, when you have all together the clinical and the laboratory results, you will finally decide if the situation is suggestive of bacterial meningitis. Then you will need to start the corticoid treatment and the antibiotic treatment if you did not start in this situation. And don't forget to start the isolation of the patient, the contact prophylaxis, and just think if the patient will need intensive care. And in cases in where the data is suggestive of viral meningitis, just only to consider the acyclovir treatment. Next slide. Then we will mix all together and move on to a clinical case for practicing this workflow and all the recommendations that Dr. Thankur has explained. The case illustrates a child, 4 years old boy, presenting with fever and headache in the last 28 hours and vomiting and photophobia in the last 6 hours. As previous data, he was diagnosed with acute otitis and treated with amoxicillin. He was correct vaccinated and without any other medical condition. Then non-specific but concerning symptoms appeared, and he had progressive somnolence and early signs of neurological compromise, including Kernin and Brudzinski signs positive, and a Glasgow Coma Scale around 11. So we monitored the patient, and the vital signs suggest intracranial hypertension. Patient was with high arterial pressure, with a relative low heart rate. So the triangle was unstable, and we start with oxygen, a peripheral line for perfusion. We took blood sample and cultures. There was indicated cefotaxime IV and also hypertonic saline serum IV. Because of the clinical condition and the neurological sign, we indicated a CT in which we found mastitis and MPM. Next slide. This slide shows the rapid escalation required when neurological status decline and signs of intracranial hypertension persist. Then the patient was transferred from the emergency room to the pediatric intensive care unit because the Glasgow scale dropped up to 10. The lactate was really high, and patient presented with metabolic acidosis. Then in the ICU, the patient required mechanical ventilation. Central line was indicated for hyperosmolar therapy and hydroelectrolytic correction because an hyponatremia. And the management also includes and early involvement of neurosurgery. Next, please. It implied a surgery drainage, and we found positive Streptococcus pneumoniae in the PCR taken from the pus. Finally, unfortunately, the child's condition improved and he was discharged to the general ward with follow-up for any lasting effects. Early audiological assessment was also done because it is recommended within 48 to 72 hours once the child stabilized, and long-term neurocognitive evaluation was essential as subtle deficits may appear months later. Therefore, the case stresses that imaging should not delay antibiotic treatment and highlights the importance of identifying complications early. Next slide. Viral meningitis is also possible and typically follows a more benign course, but differentiation from bacterial meningitis can be difficult. So clinical red flags like severe alteration in consciousness, focal deficit, or seizures should lead to consider the viral meningoencephalitis. On the other side, depending on the virus, we could find more etiological suggestive data, as for example in the enterovirus, diarrheal or flu-like illness, sometimes papovesicular rash, or in the herpes infection, the existence of vesicles. But summarizing, most viral meningitis cases only require supportive care. Just remember hydration, electrolyte repletion, pain management, and also be careful for some complications. However, next slide. Herpes infection and varicella zoster infections will require immediate initiation of acyclovir at these doses and for 10 or 14 days, depending on the severity. And of course, early PCR testing can be a very good support for the rapid antibiotic stewardship and helpful to avoid unnecessary hospitalization. In any case, it will be necessary to consider other causes of septic meningitis, depending on the context, the CSF results, the PCR panels, and the evolution of the patients. Next slide. And what about neonatal cases? Considerations for bacterial meningitis in these patients includes differentiating between early and late meningitis, as all we know. The early bacterial meningitis is considered when occurring during the first week of life because of vertical transmission, mother to child, and through the birth canal. And late bacterial meningitis occurs between the 2nd and 6 weeks, and it is secondary to transmission in nosocomial infections or horizontal person to person. With respect to the etiology, it has been previously commented that Streptococcus agalactiae and E. coli causes 2/3 of all the cases, and nowadays, because the preventive penicillin treatment in women colonized with Streptococcus agalactiae, all this problem has been decreased, and the incidence of this kind of meningitis has improved so much. I would like also to remember that the symptomatology in these neonates and these very young patients is unspecific, as we have previously commented. And this is because in neonates, the pathophysiology differs due to immature immunity, increased permeability of the blood-brain barrier, and higher bacterial loads. So the disease usually progresses rapidly and often occurs together with sepsis, pneumonia, or urinary tract infection. And empiric therapy usually needs to combine ampicillin and third-generation cephalosporin. And Usually we treat the patients for quite long days. Hospital stays are also long, and complications such as seizures or hydrocephalus and hearing loss are more common sometimes than in other patients. Next slide. And we are closer to the end of the presentation, and just to make some considerations for immunocompromised patients. They have, of course, some major differences we need to have into account. An important point is that they are at a higher risk of acute meningitis because of different kinds of immunodeficiency. For example, in cases with T-cell deficiency, of course in solid organ transplant, or maybe other patients with asplenia or prolonged corticosteroid treatment are at high risk of this infection. Another relevant point is that these patients present with less typical signs, and for example, we can observe the absence of neck stiffness, fewer meningeal signs, and all these and less typical signs can delay recognition of the meningitis. Lumbar puncture is also challenging because in these patients sometimes we found an absence of pleocytosis, and this could make confusing in order to discharge the meningitis. And other important thing is that commonly we will need to repeat the lumbar puncture 2 or 3 days after the beginning of the treatment in order to monitor the treatment response. It would be more mandatory than in non-immunocompromised patients. Just remember, with respect to the etiology, that fungal infections are quite likely in this kind of patients. For example, infections by Cryptococcus or even Candida and Mucor. And altogether with the immunocompromised situation confers a greater morbidity and altered prognosis. So we need to think in these etiologies. And finally, treatment must be broad initially and then tailored when pathogens are identified. It's a very crucial point to have into account. And another conclusion in this immunocompromised patients is that when these patients are contact of a meningitis case, please remember the prophylaxis in order to prevent this very severe infection in this very vulnerable patient. Next slide. This is all from my side. Thank you for your attention, and I think we are going to move to the Q&A.
Perfect. Great. Thank you so much. Thank you to our speakers. Just a quick reminder for our audience. So we will be moving more into the Q&A portion of the webinar. So just don't forget that you can submit questions in your control panel at any point during Q&A, and then we can address those as we move along. We do have some questions, though, to get us started. I see that we have already been submitted a few questions here. So the first was in terms of future plans for the World Health Organization's meningitis guidelines. So this question says, are you aware of future plans for the WHO's meningitis guidelines, such as expanding recommendations for specific patient populations or developing work aids to guide implementation in challenging environments? Any thoughts there?
I can address some of this. So there are a number of activities that are happening. There is a very active working group which is involved in developing an outcomes tool to evaluate for complications and sequelae of bacterial meningitis. And so that will be leveraged. And then there's plans, like I mentioned, the research gaps that were identified. There are plans to develop and partner with various organizations, academic medical centers to really address some of the gaps, especially in resource-limited settings, so partnership at certain sites that have collaborations, WHO collaborating centers, et cetera. And then with respect to addressing other key populations, I think one of the kind of challenges, I guess, and opportunities is that to have an all-encompassing guideline can be challenging, although there's certainly overlap with respect to the diagnosis and management of acute bacterial meningitis with, as was mentioned, viral etiologies. And so there is a broader scope that is addressed in the meningitis guidelines, although not specific recommendations with non-bacterial etiologies. And I think that was really purposeful because, it can get complicated in terms of addressing certain aspects of management, for instance, with TB meningitis or cryptococcal meningitis. And those guidelines actually exist. So there are cryptococcal meningitis guidelines. There's been a recent technical brief on encephalitis. So we are seeing more publications coming out on neuroinfectious diseases, which I think is exciting and important.
Very exciting. Iolanda, anything to add there?
No, I agree. I totally agree with Dr. Thankur. I think that people need more specific algorithms, more specific diagnosis and treatment recommendation for these specific populations, as for example, neonates or immunocompromised patients, and also for this differential diagnosis in cases with aseptic meningitis, even with autoimmune meningitis, which I think it's really a problem nowadays because we face with these situations in which you have a healthy children, a healthy child with this aseptic meningitis, and sometimes you can diagnose an autoimmune problem, and it's difficult and challenging. So I think these points could be the key for new recommendations and new guidelines. Yeah.
Amazing. Next question here. So we have someone who's asked, penicillin seems to be a common first-line drug for bacterial meningitis cases. Have you seen any trends of antibiotic resistance to meningitis cases, and what organizations are monitoring this? Great question.
Dr. Thankur, if you want.
Yes. So, it's interesting. We actually reviewed the data on this in terms of antimicrobial resistance, and there's a branch globally that evaluates for this, as well as regionally, a lot of ministries of health are able to monitor for this. But really, overall, there's a lot of data that is missing with respect to penicillin resistance. And gaps in terms of our knowledge with respect to this, which is a really big challenge. We've certainly seen penicillin resistance, even cephalosporin resistance with bacterial meningitis here in the United States. And so that's a broad recommendation here, but there are major gaps with respect to this across the world, especially in epidemic situations, just because of the parameters of testing for antimicrobial resistance can be particularly challenging. So I think that it is being attempted to be monitored, and there are huge branches in terms of global health organizations, but I think the primary data that's emerging on the ground becomes really challenging just for pragmatic reasons with respect to the ability to test, look at CSF rapidly, et cetera, as we discussed in our talk.
Yeah, Dr. Jordan, do you feel the same?
Yeah, I think so. And you, maybe the most relevant point is to very well know your epidemiology in your country and even in your setting, because sometimes being in the same country, in some hospitals or some settings, you will find some kind of resistance, and in others not. So be aware of the global publications, but always perfectly knowing about your local epidemics.
Yeah, absolutely. All right, next question. And great questions, by the way, that are coming in from the audience. Do your institutions have algorithms to guide use of PCR tests, especially for those who may not develop pleocytosis? Recommendations on how to successfully implement or optimize these algorithms? Anything along those lines?
Mhm.
Yeah, I can start, and it would be interesting to hear from you. As well. So we actually are addressing this. We do have pathways of care, and we have a neuroinfectious diseases group here, which I know doesn't exist at a lot of places in the United States and elsewhere. So we're oftentimes involved very early on in the decision making. We were one of the initial sites to look at the BioFire panel in the CSF. So that is available very readily, and we looked at implementation strategies with respect to how to deploy multiplex PCRs. And so we're very used to sending that, and we send that very early on this first CSF with culture, gram stain, et cetera, and find that to be incredibly useful. And in certain contexts, we also send off monoplex PCRs, and I think it's important that individuals, I tell my trainees all the time, not every pathogen is tested on these multiplex PCRs. So really understanding what pathogens, those 14 pathogens, which include the major causes of community-acquired bacterial meningitis, but in cases where, they may be immunocompromised, we're thinking of maybe something more unusual. It's not all encompassing. And then now, we're trying to develop more electronic medical records and utilizing things like AI to really help us hone in on our diagnostic pathways and ordering systems, which I think are so vital. But there's more I could talk about, but that's an overview.
Yeah, I totally agree. Here in Spain and mostly in Europe, mainly preferent hospitals are able to do these PCR panels. But at the beginning, you always, I think it's different depending on if the clinical case is a typical case of acute meningitis in a healthy child or not. Because in this kind of children, maybe you can do the gram and the lactate, and just with one PCR about pneumococcus or meningitis, it's easy to know the etiology. But in some atypical cases or immunocompromised patients or neonates, it's crucial to have these PCR results, and they are implemented in the algorithms. And as Dr. Thakur said, we are trying to include in clinical decision support systems by artificial intelligence, and I think it could be homogenize the way we decide to apply a panel.
Yeah, very exciting. Exciting to see where AI can be applied these days. Next question here was more in terms of clinical settings. So how often is LP performed before empiric therapy, and what are the main barriers to that?
No, I think it depends on the setting you are. I think in high-income countries, there are some publications that says that around 70% of cases have a lumbar puncture performed before they start the antibiotic treatment, mostly in emergency room. But it will decrease in low-income countries. And I think it's also challenging in more severe patients. And for example, patients who present with really bad neurology situation, of course, they are previously treated before develop the lumbar puncture. But I think in these cases, you have into account to practice it, but you delay, of course, because of the risk of intracranial hypertension. So I think maybe this is the actual situation. I don't know, Kiran.
Yeah, I agree completely. I think, I mean, this is a kind of personal passion of mine. I think there's a lot of hesitancy on many different levels to doing an LP And we know how important it is for neuroinfectious diseases, and now expanding other conditions as well. And if you look at the data, it's actually very poor data looking at the because bacterial meningitis itself can lead to herniation. So the studies are incredibly low. It's very challenging to really pick apart what the issue is. I would say even here we have major delays in terms of obtaining LPs oftentimes for various reasons, and so I think that oftentimes antimicrobials, and as they should be, are started as soon as it's suspected, which is going to save life, but we do still have major delays with.
Yep. All right. Okay, we still have some time left, so I'll go to the next question. How do you view the role of multiplex PCR according to these recommendations, especially regarding their use in resource-limited settings?
Yeah, I mean, I can take this question initially. I think there's more data that we need. Honestly, I mean, I think that really there's more data that's coming out on the use of multiplex PCR in resource-limited context, but I fundamentally think they could be really a game changer, because if you think about just the logistics of obtaining the CSF, getting the CSF sample volume, and then being able to run PCR on one sample from multiple pathogens, that really could be huge in resource-limited settings. And so I think we need to really study that more effectively. In terms of where it lies within the guidelines itself, it's really not seen as a replacement, but that it really should be used in conjunction with other tests, including, our gold standard, Ramping, culture, and that it can be a very important tool to utilize, which I think is important for us to recognize here. And I think that's really been the first time we've seen in an international guideline PCR testing for kind of bacterial pathogens really be so highlighted. And I think the group was very strategic about that based on the evidence that we have, recognizing there's still some limitations in the evidence.
Yeah, I also think that as far as we will have these PCR multi-test panels cheaper and easier to be done, they will be easily included in these early stages of the treatment and the differential diagnosis. I think we will attend to a really different scenario in a few years.
Absolutely. All right, next question. Not all targets may be relevant to all patients, so is there a desire to be able to custom tailor panel targets to individual patients? Anyone want to take that?
Yes, I mean, and there's been internal discussions about this. Should we be thinking about panels that maybe are more relevant for neonates versus immunocompromised individuals? I think that's the future direction, honestly. Just because we know the pathogen list is different, but I'd love to hear what you think.
Yeah, I think it's also relevant in nosocomial infections. We did not talk so much about them, but it's another situation in which you will need a tailored panel because etiology is quite different from healthy children or community infection. So very important to tailor these panels. Yeah.
Amazing. All right, another question here. How do you ensure proper collection and sample handling considerations in your individual organizations, especially with high sensitivity tests like PCR? Dr. Jordan, you want to take that first?
Yeah, in our organization, commonly we use to indicate two kind of PCR. So at the beginning, if we have a patient with community infection or meningitis in this case, we commonly only practice one or simple PCRs. But if the patient is more complex, then we start directly with the panel. So I think it would depend on the patient you have in front of.
I think, yeah, I mean, I think we also, we emphasize to everyone who's collecting CSF that, the earliest fresh sample is always going to be the most useful. Excuse me. So we really emphasize that, I mean, we handle the CSF ourselves and run it to the lab. Our trainees have been taught that, that's what we need to do to really emphasize the importance of optimizing the diagnostic
sample.
Great. I think that was our last question. So yeah, Dr. Dora and Dr. Thakur, thank you so much for joining us today and for your presentations. We really appreciate your time. And just a little bit of housekeeping for our audience. You'll see a follow-up email from us that will just have a short survey if you can just provide some feedback there. We'll also have the recording available for everyone. And if you do have any follow-up questions or anything like that, we can certainly address that after today's presentation. So we really appreciate your time today. It's been a pleasure to be your moderator. And on behalf of the team, our speakers are sponsored by Omirio. We thank you for joining. And until next time, bye for now. Thanks, everyone.
Bye. Thank you so much.
Bye. Thank you.